Now we are going to talk about one of the most important types of headaches, migraine. Migraine is an episodic headache usually associated with nausea, vomiting, and photophobia. May be associated with aura. Triggers increase migraine episodes: hangovers, orgasms, cheese, caffeine, oral contraceptives, light, lie-ins, alcohol, travel, exercise. Remember easily by mnemonic chocolate. The pathophysiology of the migraine is not fully understood. Various theories were taken place in time to time. Current theory is trigeminal-vascular theory. This explains neurovascular disorder with instability within the trigeminal-vascular network originating in the brainstem causing migraine. Neurogenic inflammation of blood vessels. Activation of trigeminal vascular system and nociceptive nerve endings release their mediators like calcitonin gene-related peptide, CGRP, neurokinin A, substance P. 5-hydroxytryptamine, 5-HT, serotonin, play a key role for this inflammation. It results pulsatile dilatation of large cranial vessels and elicits pain. There are two types. 1. Episodic migraine. 2. Chronic migraine. Episodic migraine is characterized by those with migraine who have 0 to 14 headache days per month, while chronic migraine is characterized by 15 or more headache days per month. Patients typically present with episodic type headache that usually associated with nausea, plus or minus vomiting, and photophobia. Commonly presence is unilateral headache may be preceded by focal neurological symptoms aura. Character is dull at onset and later throbbing type. Let's move to small case scenario to learn management of migraine. Case scenario. A 30-year-old woman presents with a 5-month history of episodic headaches, 4 to 5 attacks a month. The headache is preceded by zigzag visual flashes lasting 5 to 10 minutes. Headaches are unilateral, pulsating in quality, aggravated by walking and associated with nausea, sometimes vomiting, and photophobia. Each attack lasts 6 to 12 hours even if she takes paracetamol. First, you have to diagnose migraine via excluding other differentials like TIA, intracerebral hemorrhage, acute ischemic stroke, temporal arteritis, meningoencephalitis. In the management, we are mainly focused on followings. Manage acute attacks. Prevents further attacks. First-line treatment for acute attack management is simple analgesics like paracetamol. Then NSAIDs. Examples: diclofenac potassium, ibuprofen, naproxen. If those are failed, then go to triptans. Examples: zolmitriptan. Triptans are 5-HT1B, 1D receptor agonists. Triptans bind to the autoreceptors in trigeminal nerve endings and reduce neuropeptide release, which cause vasodilation, neurogenic inflammation, nociception. Also, triptan binds to the receptors in dural vessels, which causes vasoconstriction and relieve pain. So triptans are contraindicated in ischemic heart disease patients due to this vasoconstriction action. Tightness in chest neck, bradycardia, paresthesia, dizziness are the common unwanted effects of triptans. So, patient should be well counseled. Even the triptans are not working, combination therapy is the next step. Combination of triptan with naproxen. If not, CGRP antagonist or monoclonal antibodies to CGRP receptors can be tried. 5-HT1F agonist. The newer drug class has been discovered which also can be given to the arterial disease patients because they do not cause vasoconstriction like triptans. Let's move to prophylaxis treatments of migraine. Beta blockers. Examples: propranolol, metoprolol, tricyclic antidepressants, amitriptyline, imipramine, calcium channel blockers, flunarizine. Topiramate as an antiepileptic drug. 5-HT2 receptor antagonists, pizotifen. Before administration of these drugs, we have to consider their adverse effects and contraindications. Because of bronchoconstriction, beta blockers cannot be given to asthma patients. TCA has lot of known adverse effects including sedation, dry mouth, constipation. Weight gain can be happened with flunarizine. Topiramate, anti-epileptic drug, teratogenic. Not used in females of childbearing. If the patient responds well to these preventive treatments, gradual drug withdrawal should be considered after 6 months to 1 year. If migraine episodes' frequency and severity is not improved with one prophylactic drug, before move into another drug, current administrating drug dose should be increased up to maximum possible dose or maximum tolerable dose. Even if after migraine is not improving, move into another drug. This is the end of video. Thanks for watching. From your knowledge, let others to light their candles. So, share this video with your friends.